Very warm good evening to one and all present. So, today we are dealing with a session that's currently an important one. That is, we are dealing with the non-MTB infections disease today. So, it's my immense pleasure to welcome our speaker, Dr. Akshanta Ravindra, who is an assistant professor in infectious disease at Kasturba Medical College, Manipal, and she has completed her DM in infectious diseases at AIMS Jodhpur, along with a diploma in her tropical medicine and hygiene from the University of Glasgow. So she has received several prestigious awards, and including the XNet TAE Outstanding Trainee Award 2024 in the last year, and also ID Week Trainee Award 2023. So she's contributed extensively to the antimicrobial resistance and stewardship program, having co-authored many journals like articles, which are having international guidelines in JAMA Network Open, then Transplant Infection Disease and XMED, and also published in top journals like Access Microbiology, then journals of medical mycology, rheumatology, etc. So she's apart from her prolific research and academician, she's also an engaging educator through which like her YouTube channel that is Learn with Dr. Akshanta, where she organizes webinars, teaching sessions on infectious disease. So I wholeheartedly welcome Dr. Akshanta, today's speaker, for starting our session. So over to you, ma'am.
Thank you. Thank you, Anjali, for such a kind introduction, and the FCPI team and Dr. Satyanarayan for having me here. So with that, we'll start with the presentation.
Okay, ma'am.
I hope my slides are visible and I'm audible.
Yes, ma'am. It's visible.
Okay. So today's talk, I'm sure everyone will be familiar with. Before we dive into the topic per se, let's start with a case. A 77-year male non-smoker presented with 1 week history of hemoptysis. He had progressive cough for the past 6 months, which was seen by his primary care physician 5 months prior to this admission. X-ray shows right upper lobe infiltrate. He was treated with multiple antibiotics without any improvement. 2 months prior to this admission, he started experiencing night sweats, low grade fever, intermittent fatigue, loss of appetite, and significant weight loss. He was also a chronic hepatitis B carrier, not on treatment. HIV is negative. There was no history of any chronic pulmonary disease or TB. On examination, is quite cachectic with a TLC of 8,000. And this is the chest X-ray, which shows extensive right upper lobe destruction and fibrotic atelectasis. The CT scan shows pulmonary parenchymal fibrosis and chronic cystic bronchiectasis of the right upper lobe. So what do you think is the differentials here? So definitely in a country like India, such a presentation, TB should always be ruled out. TB is top. So TB, bronchiectasis, nocardiosis, aspergillosis, in endemic area histoplasmosis, or definitely non-infective like lung cancer should also be considered, especially as a smoker. So as the sputum was sent for AFP, which showed acid-fast bacilli, TB-NAT was negative. As you all know, TB-NAT is a marker for TB, which was negative. Yet, the patient was started on anti-tubercular treatment, which I am sure is very common practice. Despite the treatment, the sputum AFB smear continued to be positive. 10 days later, broth medium, that is midget culture, came positive, which was showing AFB positive with MPT64 antigen negative. Subsequently, the DNA PCR detected Mycobacterium intercellular. So that brings to the topic of my interest, that is NTM infection. What a clinical pharmacist must know. So this is a very common scenario, and at least this patient had the culture positive. Otherwise, these such patients will continue to receive multiple courses of tubercular treatment, including HRZD, which sometimes the patients can have some sort of response. But uh, uh, this is very important to identify NTM. So before starting, for disclosures, I don't have any relevant financial relationship with any commercial interest. And this is the learning objectives for today: understanding the epidemiology, risk factor, classification, and clinical presentation of NTM infection, the pharmacotherapy principles and the key drugs, to identify the drug-drug interactions, the therapeutic drug monitoring, drug adverse events, and monitoring needs. So, what are these NTM? So, NTM stands for non-tuberculous mycobacteria, which is not assigned to either Mycobacterium tuberculosis complex or Mycobacterium leprae. So, if you broadly classify, Mycobacteria includes your TB, leprae, and your NTM. It is also known as environmental mycobacteria, opportunistic mycobacteria, atypical mycobacteria, and or MOT, previously known as MOT, that is mycobacteria other than tuberculosis. What are the typical characteristics? It is found usually in the environment. It can be an opportunistic pathogen in humans as well as animals. As of 2020, more than 172 different species with distinct virulence factors have been isolated. And uh, why is it getting more importance nowadays? Because uh, initially it was not considered to be pathogenic. Now we are very well known that this could be pathogenic as well. From 1950s, we have direct evidence it causes the disease. And with increasing patients with HIV and wider recognition and newer investigations which is available, we are getting to know more of NTMs. So, are the NTM infections actually increasing? Yes, in one way, yes. In one way, no. There is increased exposure because there is greater exposure to the aerosols. There is a lot of invasive procedure. The plumbing, there is change of plumbing, and one other important reason why NTM infections is increasing is pseudo increase, because we have better diagnostic methods and culture methods, and more patients are investigated well with CT scans, etc. Then there is a lot of patients who are becoming more susceptible to such infection. We have a lot of aging population, more and more patients coming with chronic lung disease, more immunocompromised patients like transplant, etc., malignancy. And when it has also been noted that wherever the tuberculosis burden reduces, there is increased risk of NTM, which is seen in Europe, where they are seeing a lot of NTM cases, where we all know that the prevalence of TB is much lower. Other factor which could contribute, is there any, could be the virulence factor itself, but that again is a postulate. So one other important thing, in India, the NTM lung disease infection rate is underestimated because, as you all know, we have the TB endemicity is more than around 80%. So wherever there is TB endemicity, the NTM rates tend to be underestimated. And obviously, we are having such forums, open forums, more of recognition of the disease, so increased awareness about the disease. And coming to the classification of NTM, NTM can be broadly classified into slow growers and rapid growers, depending upon the growth rate on the midget medium or the liquid medium. So the organisms which show more than which take more than equal to 7 days are classified as slow growing, and which grow within 7 days is rapidly growing. In the slow growing, we have photochromogens which produce pigment on exposure to light, scotochromogen that is producing pigment when in the dark, and non-chromogens. Photochromogens include your Mycobacterium kanseri, Mycobacterium marinum, scotochromogen, Mycobacterium scrofulaceum. Non-chromogens include your important species, that is a MAC complex, that is Mycobacterium avium complex, which includes your avium intracellular. Then Mycobacterium chimera, ulcerans, xenopi, All of these come under the non-chromogen. Rapidly growing Mycobacterium includes your Mycobacterium abscessus. Mycobacterium abscessus has very important subspecies, subspecies abscessus, subspecies boleti, subspecies messelensi. Other important rapid growers include your fortutum and chelone. So there are lot many species. These are the important clinically relevant ones. And it is equally important that you identify the species and especially in case of abscesses to identify the subspecies as well. Why? I'll be talking in further slides. So, how does this NTM differ from tuberculosis? As we all know, tuberculosis is obligate pathogen. It requires host, whereas NTM is not obligate pathogens. It can live easily in the environment. NTM is generally known to be low virulence, but TB is always pathogenic. And as you all know, TB is definitely have higher rate of human to human transmission. NTM previously it was not thought it is not associated with human to human transmission, but there have been some cases of Mycobacterium abscesses, especially in cystic fibrosis community. There is increasing rates of NTM. Mycobacterium tuberculosis in general, the rates are decreasing, especially in developed countries. In India, again, overall, when we look at it, there is some reduction, but again, we have lot of endemicity with a prevalence rate of more than 80%. And Mycobacterium complex, MTB complex is a very defined group with around 6 to 8 species, whereas NTM is a large subgroup. So they differ in terms of pathogenicity, infection rates, and transmission routes. So this is how an NTM and TB differs on microscopy. If you see the first image, there is absence of this. So if the cord formation is typical, especially in the culture smears, which you see the cord formation is typical of your TB, whereas your NTM will not have such cord formation. And if you see, NTM is in general uniformly acid fast, whereas Mycobacterium tuberculosis is usually not. It is non-uniformly stained and long and slender, whereas NTM tend to be short and stout. So again, another important thing is the treatment. Mycobacterium infection in general is associated with lot of treatment challenges, especially NTM. Why? Because as I have mentioned, they are associated. They have lot of species. Each species have different susceptibility. The duration again, I'll be discussing how is it different. So TB, we do have pulmonary TB, which can nowadays there are trials for shorter therapy with 4 months, as low as 4 months. Whereas NTM, again, the duration may be as high as definitely 12 months. There is increasing resistance in NTM. Lot of drugs are used in NTM, and it is associated with higher toxicity. And again, we don't have much data on the efficacy as well. And NTM is notorious for recurrences and relapses. TB again, it has its own challenges, but NTM is more but in TB is more killing as well, whereas NTM may be slow and indolent, but all these treatment challenges make it very difficult to treat. So, what are the sources of NTM? How do you get an NTM infection? So there are basically anything can be a source of NTM infection, like natural water, man-made water sources, aerosols, even your soil, environment, etc. There has been lot of NTM outbreaks, which is associated with tattoo ink due to contaminated ink, and there are a lot of species which can be associated. Again, this is not an exclusive or complete list. So whenever this is again, why is it important? This is especially important in settings like where you do bronchoscopy, or you use this what is called as in case of heart transplant or cardiac surgery, you use certain machines which can be which has to be kept and which can be as houses for your NTM. So, what are the risk factors for the NTM infection? Most commonly, it is the um, lung related, that is, any patient with chronic lung disease or a damaged, structurally damaged lung can get infected easily with NTM infection. As I mentioned, environment, exposure to the environment, the soil, and nowadays the practices of tattooing, and other common risk factor is the surgery. And any device in situ, including your pacemaker, prosthetic valve, all can act as a nidus for NTM. Then there are other certain mutations, like in patients having decreased mucociliary clearance, that is seen in case of your cystic fibrosis. And in general, females have higher predisposition for NTM infection. So again, NTM can be pulmonary, extrapulmonary, which I'll be discussing further. So the risk factor can be related to the same. Previously, which whatever I have discussed, like lung related, the mutations causing decreased um, mucociliary clearance, all these can be associated with pulmonary NTM, whereas extrapulmonary in general, it is related to any contact with a contaminated source, which can be trauma, surgery, prosthetic valves or implants, organ transplantation, dental procedures, invasive devices, etc. So, coming to the epidemiology of NTM, it varies from country to country. Highest, like some studies which report, do mention higher prevalence in Japan of around 33 to 65%. Canada, USA have around 8 to 9%. Brazil has around 1.3%. China accounts for around 6.3%. India, it is 0.2 to 6%. Yes, so this is how underrepresented NTM could be, because we have a lot of TB endemicity. And coming to the species wise, again, there is a lot of heterogeneity. But in general, most common is MAC in most of the regions, including India. Other common infections in India is your Mycobacterium abscessus. So this is one study which has looked at the prevalence of NTM in India. If you look at the south zone, in general, it is MAC and abscessus, Mycobacterium avium complex and Mycobacterium abscessus, which is common in general. In south zone, we do have Chelone, MAC, Fortunatum, Gordoni, and other NTM species. So, what are the common infections or clinical presentation NTM is associated with? Broadly, it can be divided into four: the pulmonary disease, the lymphatic disease, skin and soft tissue infection, disseminated infection. Pulmonary infection or the lung infection is the predominant manifestation. And as I mentioned, it is due to various reasons like structurally damaged lung, predisposing genetic factors. Disseminated disease is usually seen in immunocompromised hosts, including HIV infection. Lymphatic infection, especially, is common in children, which affects the cervical lymph nodes, and in adults in HIV infection. Skin and soft tissue infection is due to the inoculation, most commonly by either contact with contaminated water, fish, trauma, surgical wound, etc. Nosocomial is one of the other most, after lung infection, nosocomial skin and soft tissue infection form a predominant bulk. And both the host factors and the organism is what it influences what sort of a disease, whether they will develop a localized disease or a disseminated disease, is determined by the host as well as the organism. Other manifestations include your endocarditis, genitourinary infection, bone and joint infections as well. Again, based on the site, there are certain species which are more common. When you look at the lung infection, MAC, that is your Mycobacterium avium complex, Kansasi, Xenopi, abscessus form the predominant species in lung infection. In skin, we do have Mycobacterium ulcerans, Mycobacterium marinum, abscessus, cheloni. In lymphadenitis, as I mentioned, it is most commonly seen in children. It can be most of them are associated with Mycobacterium scrofulaceum. If you remember, it's one of the scotochromogen and it is a slow grower. And in HIV patients, it is MAC. Disseminated, most commonly it is the MAC, which is very common. And I'm sure most of you will be familiar with these names. Fish tank granuloma, which is caused by Mycobacterium marinum, Buruli ulcer, Mycobacterium ulcerans. So these are nothing but different skin manifestation or the skin and soft tissue infections caused by the NTM. Fish tank granuloma or swimming pool granuloma will appear like erythematous nodule or plaque which can ulcerate. Buruli ulcer, again nodule which will ulcerate. These are different names given to specific organism causing skin and soft tissue infection. Cosmetic surgeries, Mycobacterium fortuitum, cheloni, Mycobacterium abscessus are more common, and it is usually seen in patients like how do they present after the surgery or any they can present as wound dehiscence or erythema, induration, nodule, and it can be as like late as up to 1 year to 2 years after the surgery. Post-traumatic wound infection also is um, quite common. Osteomyelitis has been known with Mycobacterium abscessus, Fortitium cheloni, and other thing is iatrogenic and post-procedural infections again is becoming more and more common. Prosthetic heart valve especially is common. So in that Mycobacterium chimeria is one of the common most important organism or species which you need to remember. So again, this is associated with heating and cooling units, which is required in heart surgeries and other organism. Like if you see in general, it is wherever you see Mycobacterium MAC as well as M. abscessus can cause most of the infections. In heart surgery, Mycobacterium chimera. Skin and soft tissue infection, you have your ulcerans, marinum, etc. So not all NTM are equal and not all NTM which you isolate is considered to be pathogenic. So if like some species are definitely, if you see get the species in the culture, it should be considered pathogenic, which includes your MAC, abscessus, Kansas, Schulrei, Malmoense. But there are certain species like Mycobacterium gordonae, Fortuitum chelone, which is in general associated with lower pathogenicity. So you need to consider in the clinical context whether you will be considering this as a causative organism of infection or was it just an environmental contamination. So when will you suspect NTM lung infection or lung disease? So a patient presenting with, you can just remember it as patient presenting like TB but not TB. It's the easiest way. So a patient can present with hemoptysis, weight loss, rapid worsening, no response to standard therapy like antibiotics, including your ATT, and there are certain radiological characteristics. So if you are suspecting, you need to send at least three sputum samples or do a BAL and send for mycobacterial culture. And in all the patients with bronchiectasis, we need to rule out NTM infection or co-infection. So why do you need to send three samples? Yes, big one, because as I mentioned, it is one of the common environmental contamination. So sometimes it can, so that is why you need to demonstrate it in multiple samples. And even in BAL, as I mentioned, there will in BAL, you're going to bronchoalveolar lavage, you're going to insert some sterile water and which will be like taken out. So that water itself could have been contaminated or would have been colonized by the NTM, which may not be causing the NTM disease in the patient. So that is why you need to send multiple samples. So when to suspect extrapulmonary NTM? a patient with non-resolving clinical picture with most commonly it is seen in post-op. The patient has this some sinus leakage with abscess or pus which is coming out. Multiple antibiotics has been given, but he's not responding. Then patient profile. I have mentioned certain risk factors, including immunocompromised patient, transplant patient, HIV. You need to think of NTM. Any non-healing ulcer, chronic discharging sinus, post-surgical site infection. And what are the lab findings which will raise suspicion of NTM? AFB positive with gene expert negative. So again, if you remember from certain basics, like usually the staining has lower sensitivity compared to your expert. So if your staining is picking up AFB, but your expert is negative, you should consider NTM. It's not necessarily all are NTM. Sometimes the sample which is sent for staining may be different for but than the sample sent for experts. So there can be spurious cases of false negative, but definitely you should consider NTM in such situation. And culture growth in midget or LJ medium from sterile sites, like you're sending um, your blood culture. When if your blood culture is growing on midget and LJ, it is more likely to be NTM than your TB or lepre. Then CSF or pleural effusion, ascitic fluid growing your NTM, you should be considered. And chronic granulomatous inflammation on histopath without TB confirmation. So most of the time we do see the reports of chronic granulomatous inflammation and the patient will be initiated on ATT without confirmation. So that is also the time you need to consider NTM in as a possibility. So this I think I have already stressed upon when to suspect non-healing ulcer, lymphadenitis, especially in children, uh, bone and joint infection. They will present as chronic osteomyelitis or monoarthritis, any prosthetic joint infection, trauma, surgical or device-related infection. You should be considering the NTM. So what about the diagnostic? So what are the microbiological tests you need to send? Microscopy, definitely you should look at the AFB, though the sensitivity is low, but the cost, and I'm sure all the places will have this. Again, if the load is quite high, you can, as I mentioned, you can easily differentiate between your NTM and your Mycobacterium tuberculosis or based on AFB smear. So if it is positive, they can be able to find, mention or suggest that it could be suggestive of NTM. Then direct molecular detection on primary sample can be done with the help of certain NATs, like your CB NAT. There are other NATs which is available for your NTM. Again, this has good sensitivity and specificity, but again, uh, not many places will have this. Next, gold standard is the culture, Mycobacterium culture. Liquid culture has better sensitivity than your solid cultures. Both have it's a gold standard, so very high sensitivity and specificity, and it's a more sensitive method to detect NTM. But the results will be available late, even like as I have mentioned, like slow growers, rapid growers. But do not expect that all the samples will, like all the slow growers, all the rapid growers will grow within 7 days. You need to incubate longer sometimes. Then for speciation, we do have certain tests like LPA. Like TB, there is a LPA which is specific for NTM. Malditoff is one thing which most of the places use for speciation currently. Definitely now it's the like era of whole genome sequencing. So if you can do, if you can, the patient can afford, and you have a place which can run this, it is one test which has got good sensitivity, specificity, as cost wise also it is like it will save patient lot of time and efforts. You will get the species directly. So next, coming to the antimicrobial susceptibility testing. Again, the methods vary. There is CLSI and ATS IDSA have criteria for AST. the gold standard is broth microdilution method, but the MIC standards have been established for most rapid growers, and for other species which are it like for in the rapid growers it is for your Mycobacterium fortuitum kiloni abscesses. But for the other rapid growers it is just extrapolated from this data. Next, in general, what are the panel or what are the tests you need to look for in slow growers? That is MAC, Kansas, etc. Typical AST panel can involve amikacin, cipro, clarithromycin, clofazimine, doxy, linezolid, and wide array. But you need to remember there are very limited clinically relevant ones. Of importance is your clarithromycin and amikacin, which is predictive of the clinical response. In rapidly growers, again, you have a wide array of the drugs which can be tested. So in this, AST is performed to guide rather than dictate the therapy because there is wide interspecies variability. So suppose, for example, for MAC, there are two commonly used drugs which is tested, clarithromycin and amikacin. Clarithromycin, but it's not like only two drugs is used. You add with this either ethambutol and rifampicin, but ethambutol and rifampicin or rifabutin has poor clinical correlation with the outcome, so they need not be tested. So only these two drugs, clarithromycin and amikacin, is tested. In cancer, see, rifampicin is a key predictor, so that is one drug which has to be tested. Clarithro, if there is rifampicin resistant, you need to consider the testing of clarithromycin. So, just briefly about the diagnostic criteria for NTM lung disease, we have a lot of societies which is describing this, the ATS IDSA criteria, where there is a radiological criteria, microbiological criteria, and a clinical criteria. Radiological criteria, as I mentioned, the specific radiological picture includes nodular or cavitatory lesions on chest X-ray, or multifocal bronchiectasis with multiple small nodules, and exclusion of other cause. This is very important. Exclusions like TB, most commonly TB should be ruled out. And so you have sent 3 samples. If you remember previously I said for TB, NTM lung disease, you need to send three specimens or 3 sputum samples. In out of 3, if 2 positive cultures are there, or 1 positive culture from bronchoalveolar lavage or biopsy is considered as microbiological criteria. And clinical criteria is the symptoms which I mentioned, the bronchopulmonary symptoms like hemoptysis, cough, persistent cough, weight loss, etc., and with exclusion of other lung disease. So this is the diagnostic algorithm. So for, in suspected, you send the 3 sputum. If all samples positive or more, 2 samples is positive, you look at the radiography. If it is having the clinical picture or the radiological features I have described, it is considered as NTM lung disease. If only 1 sputum is positive, HRCT, if it is suggestive of NTM, you can go for bronchoscopic lavage ball, and if you then again culture is positive, it will be considered as NTM lung disease. So next, moving on to the treatment. The treatment, as I mentioned again, there are a lot of guidelines. The BTS, that is British Thoracic Society, ATS, that is American Thoracic Society, European Respiratory Society, ECMED, IDSA. The most recent one is the ATS ERS ECMED IDSA 2020, and so I'll be talking about these 2 guidelines in specific in further slides. So how do you decide whether to treat this patient or not? It is based on few important questions. Is the disease positive by sputum culture? How pathogenic is the isolated NTM? As I mentioned, not all are pathogenic. Next is whether what type of disease is it? Is it cavitatory or is it nodular and bronchiectatic disease? In general, multi-drug therapy. Just like TB, monotherapy is not preferred. You do give a multi-drug therapy. So again, reiterating MAC, the AST for MAC, what are the drugs you will test? Macrolide and amikacin. And the breakpoints are provided only for those. Rifampicin and ethambutol have not been shown to correlate with the activity. So for MAC, if you remember our patient which I discussed in the first slide, I had Mycobacterium intercellular in the sputum culture, which belongs to the MAC group. So, what are you going to give the treatment? The treatment depends upon the type of radiological picture. That is, whether if it is nodular bronchiectatic, three drugs regimen, that is rifampicin, ethambutol, azithro or clarithrol for is the treatment of choice. And if it is nodular bronchiectatic, the patient is not very severe, you can even give only 3 times weekly dose. If it is cavitatory disease, you need to consider three, or sometimes if the disease is severe, more than 3 drugs, which includes your azithromycin, rifampin, ethambutol, and IV amikacin, or especially for the induction phase. Then in this case, you have to give daily. IV aminoglycoside can be considered 3 times weekly. And as I mentioned, NTM is very prone for relapses as well as recurrences. So, in case of refractory NTM, you need to consider adding the fourth drug. And nowadays, there is increased use of amikacin liposome inhalation suspension, which can be considered. And like TB, the drug combination is not fixed. Based on your patient profile, what is the, like, some patients may be allergic, may not be tolerating certain drugs, you can always look for the substitution. Alternative drugs for MAC which can be used is clofazimine, moxifloxacin, linezolid. So, and other important things we need to remember is NTM lung disease is not just, like TB, it is not only about the drug. You need to evaluate and address the predisposing condition, whether there is a what type of, like if there is immunocompromising condition, that needs to be addressed. For structural lung disease, you should advise relevant respiratory physiotherapy. Sometimes GERD also is one of the risk factor for the NTM infection, so that also should be addressed. Management of underlying bronchiectasis and co-infections. So NTM can coexist with TB. It can coexist with other fungal infections like aspergillosis and definitely polymicrobial infections as well. So you need to give adequate airway clearance and use of antibiotics for other pathogens as well. Monitor the progression with repeat imaging, repeat pulmonary function testing, and sputum sample, looking for the culture positivity. And most of the time, the patient will go back to the same surroundings or the environment. So you need to also minimize the exposure to the concentrated exposure to the environment if the patient is working in an environment with lot of NTMs. So for evaluating the response to the antimicrobial, we need to consider the patient radiological and microbiological criteria. uh, Apart from the pharmacological treatment that includes your antimicrobial, anti-inflammatory, and symptomatic management, non-pharmacological treatment is equally important because these patients, remember, they'll be on drugs for longer time. So patient education is equally important. Airway clearance therapy, exercise training, inspiratory muscle training, nutrition, and psychological support are equally important. And just like endocarditis, NTM management is a teamwork. It requires multidisciplinary team which composes of pulmonologists, ID specialists, clinical pharmacists, surgeons, respiratory therapists, nurses, social workers, patient support groups, a clinical microbiologist, and pathologist. So it is a multidisciplinary team effort. So, with that, we'll move to the next case. A 79-year-old female with complicated urological history presented with urinary retention and frequent urinary tract infection. She required indwelling catheter for several months due to this retention. Multiple infections was treated with cotrimoxazole and for long duration between November 2016 to June. In June, she had more UTI infection, which improved on intermittent antibiotics. And from Jan 2019, her symptoms became almost constant. Repeated cultures were positive for MSSA. Feb 2019, there was some kidney stone which was noticed, which was removed. Unfortunately, despite this intervention, she constantly had the symptoms of UTI. She also underwent cystoscopy in 2019, which shows inflammation but no mass, and biopsy was not performed. Urine cytology showed no malignancy, abundant inflammation, and significant candida. CT imaging showed thickened urinary bladder consistent with cystitis. So, persistent symptoms, pyuria, and urine cultures were sent every time it was the urine cultures were negative. In routine microscopy, candida was seen. She was treated with an antifungal medication for the candida cystitis. So what was missed here? So there was sterile pyuria. Remember, whenever there is sterile pyuria, you need to think of mycobacterial disease, including your TB. Urine sample was then sent for AFB, which was AFB positive, and culture eventually grew and was identified as Mycobacterium abscessus. So what went wrong here? Initial management, she has got multiple antibiotic courses without evaluating for the possible etiology. There were multiple recurrent infections which are not fully investigation. Every time given some antibiotic, symptoms persisting despite any the stone removal, cystoscopy. They did, but then they didn't perform biopsy. Candida in urine. Remember, it's not candida in urine is very rarely pathogenic. So, but it is one of the most commonly treated condition. So, candida in cytology could have misled and antifungal was not required. Sterile pyuria, which was always persistent, was overlooked. So, and AFB and expert TB cultures were not performed. So, AFB cultures was performed very late. So, what are the critical learning from this case? One should not ignore sterile pyuria. It may indicate tuberculosis or NTM. And whenever there is patient with chronic UTI symptoms not responding, consider NTM. AFB urine culture should be sent early in such these patients who are having chronic sterile pyuria. And whenever you perform any like cystoscopy biopsy, so patient having so many symptoms for so long, whenever if you perform an procedure, you need to consider biopsy to rule out, I mean, not only infective, non-infective etiology as well. So talking about Mycobacterium abscessus, here what is very important is your macrolide resistance. There are two types of macrolide resistance in Mycobacterium abscessus, that is mutational resistance and inducible resistance. So mutational resistance is called due to mutation in the RRL gene, which causes high level of resistance. Inducible resistance is due to the erythromycin ribosomal methylase gene, that is ERM gene. Uh, so here, this is where your subspecies of Mycobacterium abscessus becomes important. Subspecies abscessus has and boleti has the maximum inducible resistance, whereas mesalensi has zero. So that is why you need to subspeciate the Mycobacterium abscessus. And how are you going to detect this? Either by sequencing or LPA. And when are you going to detect the resistance? In case of high level resistance or mutational resistance, you will get to know within 3 to 5 days. For inducible, you need to incubate for longer. So let's understand with this. So looking at macrolide, that is macrolides include your clarithromycin, azithromycin. Clarithromycin is the one which is usually tested. So if on day 3 and 5, the drug is susceptible 3, and on 14 it is susceptible. The susceptibility phenotype finally it is macrolide, and most commonly it is the subspecies is mesilensis. If it is susceptible on day 3 but resistant on day 14, this means it is functional ERM, that is inducible macrolide resistance. It is most commonly seen in abscesses and bulleti. If it is resistant on day 3 or 5, it indicates constitutive macrolide resistance, that is inherent. So it could be in any of the species. It is due to the mutation. And whether do you use clarithromycin? So if it is come irrespective of the susceptibility, in Mycobacterium abscesses, you are going to add the macrolide. But if it is susceptible, you going to you count it as it as an active agent. But in other scenarios, you are going to use macrolide for its anti-inflammatory property rather than an active drug. So coming to the treatment, so in case of first and foremost, you should look at macrolide resistance. If there is resistance, you should initiate the initiation phase with at least 4 drugs, 4 or more than 4, in which IV drugs should be around two or at least two to three, and oral drugs can be 2 to 3. Again, how are you going to decide which drug? This will be based on your susceptibility. So that can be most commonly what we use is combination of amikacin, imipenem with macrolide, azithromycin, clofazimine, and linezolid. If it is resistant, even though you're adding azithromycin, it should not be counted as an active drug. So if there is no resistance, you can go get away with 3, at least minimum 3 or 3 to 4 drugs. So in that case, you can use initiation phase amikacin, imipenem with azithromycin, clofazimine. And later, after 2 months, you can put the patient on continuation phase, where you are going to use at least two to 3 drugs is one what you prefer, where you can use azithromycin, clofazimine, linezolid, tedizolid, bedaquiline, umadacycline, or inhaled amikacin. So this is a table which like summarizing the treatment for Mycobacterium abscesses. And nowadays we do have newer therapies, including your tedizolid, dual beta lactam fast therapy, and NTM drug pipeline is increasing. So we do have lot of new drugs which is coming, and more than new drug, there are certain drugs which are like reintroduced or for the treatment of NTM. So how do you, so this is an ideal scenario where you have isolated the NTM in the from the sample, and you have the species, and you have the susceptibility. But in majority of our scenarios, either you don't have, I mean, you have a suspicion of NTM. There is AFP positive, culture negative, but sometimes the NTM may not grow. So sometimes you may not have the species. Sometimes you, even if you have the species, you will not have the susceptibility. How to approach in that case? So confirm the likelihood of NTM. Look at the symptoms, whether the extrapulmonary or pulmonary symptoms, whether it's matching. Then the imaging findings, like I said, nodules, cavity, bronchiectasis. AFB smear should be negative. Positive. Expert should be negative. Assess the disease severity, whether it is severe disease like cavity, rapid progression, immunosuppression, like presence of immunosuppression, etc. And if non-severe, if it is nodular bronchiectatic and patient is quite hemodynamically stable, then consider what is the likely NTM species. In pulmonary, it is your MAC, cancer, C, abscesses, as I mentioned before. And in case of skin and soft tissue, again, abscesses, chyloni, fortuitum, etc. Look for the history of prior antibiotic use. Because as I mentioned, macrolide is one of the reason for, you exposure to macrolide could lead to the macrolide resistance. So wherever the patient has been on longer duration of macrolide monotherapy, there can be higher resistance. Where is it concerning? Patients, as I mentioned, there is common risk factor for NTM is bronchiectasis, and these bronchiectasis patients are put on azithromycin prophylaxis. So in that cases, especially, you need to consider macrolide resistance. Start empiric therapy if there is severe disease, high suspicion, and pending cultures. And in case of pulmonary, you will in general cover for the MAC, which can include azithro, rifampicin, ethambutol. In case of suspected rapid growers, you can use IV amikacin, imipenem, macrolide, clofazimine with or without linezolid. So this is the empiric therapy you can consider. Though none of the guidelines mention empiric therapy, everywhere it does mention based on the culture and the susceptibility. And send the cultures, follow the susceptibility, and reassess when the culture are back, and titrate uh, the the treatment according to the species. So sometimes you do have the species, so but you are not able to perform the AST. Then how do you guide the therapy? This is an excellent article where they have looked um, given the various species and the expected drug which are expected to work. So green indicates they are going to work. So MAC, as I mentioned, azithromycin, ethambutol, rifampicin, with or without your ALIS, that is your amikacin liposome inhalation solution. Then Kansas, it is Kansas is just like your TB, so most commonly it is HRE with rifabutin, ethambutol, azithro, which can be used. So this is a guide which you can refer in case you have the species but do not have AST. And this is a chart overall summarizing the NTM, MAC, as well as recommended treatment with induction and continuation phase. It's very difficult to remember all of it, and there are a lot of species. So I would say at least you must think and remember the MAC abscesses, because rest of it is a combination of multiple similar, based on whether it is rapid grower or slow grower. You decide and titrate or manage the regimen. So what is the role of a pharmacist, clinical pharmacist or ID pharmacist? There are a lot of drug and drug interaction. You need to consider that. TDM, which drugs require TDM, adverse effect monitoring, other than support. These people will be on long-term NTM, treatment. So there is required to support patient education on the dosing, regimen, how to take, coping with the side effects. In stewardship, definitely there's a role avoiding unnecessary use of broad spectrum antimicrobials until NTM is confirmed, and support regarding the guideline concordant treatments. Long-term patient follow-up is necessary, and ensuring adequate medicine supply and introducing newer uh, drugs into the formulary. And just a brief on the drugs. I am sure you will be more familiar with this. So the commonly used drugs, and what is the dosage, what are the common adverse events, the effects which you need to monitor. I'm sure you guys will be more familiar with this rather than me talking about it. Just like amikacin, aminoglycoside, and like any other aminoglycoside, nephrotoxicity, ototoxicity, vestibular toxicity is very common. The dosing is almost similar to the usual dosing. Azithromycin 250 to 500 mg PO. You need to look at the do the ECG to look for the QTC interval, and there are quite a lot of side effects with azithromycin. But azithromycin is a cost lesser than clarithromycin. So many people do preserve. And it is a single day single dosing. So people prefer azithro over clarithromycin. Bedaquiline is one of the newer drugs in the NTM. In India, using of bedaquiline outside the TB context is difficult because bedaquiline is supplied only by the government, and most of them will not be giving or supplying it for NTM. It requires permission. So clofazimine is another important drug, which is a very good alternative. Alternative recommendation, alternative drug which can be used in many NTMs. Um, it is very safe, renal safe and liver safe, and especially in patients with CLD or CKD, it can be used. Uh, an important test includes your liver function test and ECG, which should be monitored. Important side effects which you need to counsel the patient is the pigmentation, and to you should tell that the pigmentation will persist even up to 6 to 8 months after stopping the therapy. And other drugs includes your doxycycline, ethambutol, imipenem, moxifloxacin. And this is one uh, overall picture of what are the things you need to monitor in the drugs. I mean, it's very difficult to remember all of it. Maybe you can give one such chart to the patient where you mark what the drugs the patient is on, and what are the monitoring requirements. If you can explain it to the patient, or you can keep it with you, it will be useful for you as well as a patient. And therapeutic drug monitoring, again, like in other antibiotics, even it is equally important in NTM as well. So there are certain drugs which where therapeutic drug monitoring is important, which includes your amikacin, tobramycin, azithromycin, clarithromycin. uh, Amikacin, tobramycin, due to the toxicity. Rifampicin and rifabutin, again, because there is due to the drug interaction and variable absorption. Linezolid, because of the lot of adverse events, including your um, anemia, neuropathy, lactic acidosis. Other drugs, it is rarely used, like your clofazimine, isoniazid. Rarely TDM is recommended. So, what is the duration of the therapy? In general, remember, most of the disease, it is 12 months after culture conversion. So, so the first culture which is positive should not be considered. You shouldn't consider duration from that time. That is why it is necessary that you repeat the cultures every like 3 to 6 months, because that is how you're going to decide the duration of therapy. From the day of culture negative, you should give for 12 months. So in most of the scenarios, it is so. In case of HIV, you need to give secondary prophylaxis till CD4 is more than 100 for 3 months. Where you can give lower duration is in case of skin and soft tissue infection, and in case of lymphadenitis, if the source control or the complete lymph node has been removed. In skin and soft tissue infection, maybe you can stop after 4 to 6 months, but you should monitor clinically and microbiologically. The patient should be like, there shouldn't be any symptoms, as well as culture should be negative. So most other places, it is 12 months. In catheter-related bloodstream infection, remove the IV catheter if possible. Treatment should be given for 1 to 3 months, depending upon the immune status as well as the NTM species. So that brings us to the end of the discussion, where now I'll be just briefly summarizing what are the important treatment for this important species. MAC, it is, as I mentioned, it is azithromycin, rifampicin, ethambutol, with or without amikacin, IV or nebulization. Uh, in case of non-severe infection, you can give, that is nodular, you can give three times a week. But in severe infections like cavitatory, you need to give daily. Mycobacterium cancerci, it is isoniazid, rifampicin, and ethambutol. Remember, HRE. Xenopy, it is rifampicin, ethambutol, azithromycin with moxifloxacin. Mycobacterium abscessus, look for the macrolide resistance, whether there is macrolide resistance or not. Then commonly you can use amikacin, imipenem with or without, 2 IV, for with clarithromycin, linezolid, tigecycline can be used, followed by amikacin, clarithromycin plus linezolid, moxifloxacin, or clofazimine, or cotrimoxazole based on the susceptibility. MAC, again, in HIV, when MAC is there, whether you should give prophylaxis, it is not routinely indicated that you give MAC prophylaxis. But if the patient is not on ART, you can consider. So what is the duration of the NTM lung disease? It is 12 months after the culture negative. For disseminated NTM, again it is 12 months after the NTM infection. I mean culture negative. So the key takeaways, NTM and TB should be differentiated because the treatment, the duration, the outcomes are different. We should send 3 sequential sample if NTM is suspected for pulmonary as well as extrapulmonary. Species identification is a must because the treatment will differ based on the species. Susceptibility is required in all the scenarios, especially important in case of Mycobacterium abscessus because it has macrolide resistance which can be inducible or mutational, and you can suspect MTB, NTM in patients who are on ATT and not responding. MAC prophylaxis is not routinely indicated. So these are my references, and thank you, and thank you FCPI for having me. And in case of any queries, you can always drop in message in any of my social media accounts. Thank you.
Thank you so much. So, to us, very well covered session, covered part, and leave any portion without in like giving an information about further. And actually, I have some questions to ask. Not some. Let's do a question. How can we coordinately work with the other healthcare professionals in implementing these in some tertiary, like for example, a tertiary care hospital? How can we implement these guidelines
Okay.
along with the working?
Yes. So it is, I mean, how to implement guidelines, like most of the time, this NTM will be going to the pulmonary department, irrespective. So I think you should have good, maybe you can have connection with the, or the talks with the pulmonary department as well as more. Otherwise, it is the infectious diseases department which will be diagnosing NTM. So, how can we work? Maybe increasing awareness about NTM is one thing. Recently, August 1st was celebrated as World NTM Awareness Day. So, again, because lot of these patients, especially when in the like primary care levels, they are misdiagnosed. So, increasing awareness and maybe setting up NTM clinics. Just like, I mean, ideally, we should have NTM clinics where these patients can routinely come because these will require long-term monitoring, adherence counseling, where you can have a clinical pharmacist with another clinician like your ID, or which can be run with ID or a pulmonary medicine, so that the patient will benefit from the care as well as the proper guideline adherent treatment, I would say.
Yes. Okay. Thank you, ma'am. And also one more thing is that most of the comorbid conditions can also lead to I mean act as a triggering factor for this NTM infection. So the relapse can also happen. So in such cases, like initially maybe for the treatment accommodation, then they get to know that they are positive, culture positive for this NTM. So in that way, managing both is how we can manage.
I mean, your voice was breaking in between. Could you just repeat? Sorry.
Like for some patients, they may be coming for the morbid condition. They will be coming for treatment that they may be know their culture with NTM. So, like in case, for example, CKD condition. So that time,
Yes.
if they are provided amylglycoside, amycam like that, nephrotoxicity can also cause. How to
Mm-hmm.
manage both conditions?
Yes. So, treatment of NTM, like diagnosis is complicated. Most of the time, reaching a diagnosis is difficult. At the same time, treatment is even more difficult because most of these definitely will have certain comorbidities. That is why the guidelines is not fixed. So we need to individualize the treatment based like our based on all our expertise. That's why we need to sit together and work out a treatment plan individualized for the patient's comorbidities. Like in CKD patient, you cannot give amikacin. Yes, it's a valid point. So we need to consider alternate drugs, and whenever we use alternate drug, the treatment duration also can mean more, because it is associated with increased relapses, because these are not standard treatments we are going to use. So that is where like I think all of us will come into play, especially like clinical pharmacist will come into play to suggest what other drugs we can be using in such situation. So definitely for NTM treatment, it requires all the brains to sit together and work out a regimen which can work for the patient. Yes, it's very difficult. I cannot hear you, sorry. i I cannot hear anything now.
Valuable time spent with
Um, Nothing I'm able
us.
to hear. I can hear just blips.
And also, I have to mention that if any questions is there, that thank you for the session, for the time you have spared for us, for providing the information regarding hello.
Yeah, I can hear now. There is some delay in transmission, like, okay.
uh, Maybe some network issues. So
Yeah.
thank you for the session and the time you have spent with us. So
Mm.
I also mentioned that for in future also we'll hope for a session on another any other topic, and I would like to be the host for you also. So if any questions is they're having, they can easily or possibly mail to the HCPA mail so that you can get the answers immediately. So thanking you all for sparing your time for the session. And here we are ending up with this our session. Thank you all. Thank you, ma'am, for
Thank
the
you.
time.
Thank you so much. Thank you, FCPF, for such a great initiative. Please go ahead. You're doing really good.
Okay. Thank you,
Thank
ma'am.
you.
Thank you.